Connaissance, recherche, sciences,
des sciences, mathématiques,
théorie,
physique,
philosophie, conférences,
archéologie, nature.
Okay, thanks very much for having me here to talk about this work. This is joint with Martina Björkman at Bitekerezo. So the starting point for this work then is the poor health outcomes in many parts of the developing world. Just to give you one of many disturbing statistics, it's estimated that around 11 million children under 5 die each year, and almost half of these deaths occur in sub-Saharan Africa. And what's maybe even more striking or more disturbing is that more than half of these children, and in some places, like in Uganda, it's estimated over 70% of these children, could have been easily prevented. The deaths of these children could have been easily prevented or treated if the children had access to a small set of proven and inexpensive services. So a key question that comes out of that is, of course, why are these services not provided? And it's not a simple answer to this, and I'm not going to provide you with a simple answer. It's a difficult question. But at least one answer, one part of the answer, has received some scrutiny lately. So more and more systematic evidence points to the provision of public services being to poor people being constrained by ineffective systems of monitoring and weak accountability relationships. Just to give you some examples, schools and health clinics are not open when supposed to be, and even when they're open, teachers or health workers are not there, or spend a significant amount of time doing something else than serving the intended beneficiaries. Equipment, even when it's there and well-functioning, is not used. Then drugs and vaccines are misused and funds are expropriated. So many argue that for these reasons, strengthening the providers' incentives to serve the poor is a crucial thing. And I think many would agree that that's good. How to achieve this, though, is less clear. So the traditional approach then to accountability relies on very simplified this little figure. It has citizens holding the government accountable, and the government therefore having strong incentives to make sure that service delivery is functioning well. And typically what happens is that the government then delegates responsibility of various issues, including monitoring, to some external agent, and they're supposed to monitor the end provider, be it a clinic or a school. For many reasons, which I will not talk about here, this traditional approach to accountability is not functioning very well in many countries for various reasons. Voters cannot hold their politicians to account. The government may have little or no incentives to actually supervise providers for various political economy reasons, for instance. And the monitoring agents in many parts of the world are typically weak or even malfunctioning, and typically do not have very strong incentives to monitor providers. So for this reason, these problems with the traditional approach of accountability, people have argued that we need to supplement it or complement it with so-called local accountability, or an attempt to strengthen citizens' ability to hold providers accountable directly. And this is what we're going to talk about. This is what I'm going to talk about today. Then, an experiment where we try to assess if this works and if it's quantitatively important. So let me just summarize what we have done, and I should say that this project is actually ongoing. And as I speak here, we are collecting new data and looking at, among other things, the long-term effect of this intervention. So it's a randomized field experiment in 50 communities, and I'll be more precise what that means, from various districts in Uganda. And the intervention had local NGOs or small community-based organizations facilitating village and staff meetings in which the communities discussed and analyzed information on the status of health service delivery and relative, both absolute numbers, but also relative to other government providers and the set government standard for service delivery. During these meetings, the community members were also encouraged to develop a plan identifying problems and steps to improve health service provision. And the intention of the intervention, that lasted basically for 5 days with different meetings, was to initiate a process was then up to the communities to sustain and lead. I'll spend most of my time actually talking about the results, but just to summarize then, we find large increases in utilization. This is 1 year into the project. Large increases in utilization and improved health outcomes, measured as reduced child mortality, increased child weight. That actually compares favorably to some of the more successful community-based intervention trials reported in the medical literature. So what I'll talk a little bit about the institutional setting. I think Mary will say maybe some more stuff about that. And I'll discuss the intervention in some detail and then focus on the outcomes. So Uganda, like many newly independent countries in Africa, had a relatively well-functioning healthcare system in the early 1960s. During the 1970s and 80s, during the political problems facing Uganda, the government service delivery basically collapsed. Since then, they have spent a lot of money on health service rehabilitation, and in particular on infrastructure, although evidence on health indicators reveal a rather mixed picture of success. There are different types of facilities in Uganda. They are from the order of size: hospital, health centers, dispensaries, and aid posts. And there are different types of owners of these different facilities: government, for-profit, or not-for-profit ones. And here we're going to focus on government-operated dispensaries. And the reason for this is, first of all, there are quite a bit of dispensaries out there, so it's straightforward to do a statistical test on impact. But also this is the lowest tiers of the health system, where professional interaction between users and providers take place. So these dispensaries are mostly rural. They should be involved in preventive care and simple outpatient care, maternity, and some simple laboratory service. And in our sample, a dispensary on average was staffed by a clinical officer, 2 nurses, including sometimes a midwife, and 3 nursing aides and some assistants. Let me just say a word of this. So health sector in Uganda is decentralized, and actually, as in many other countries, the system of supervision and control of these primary dispensaries are really difficult to understand. So we actually spent a lot of time actually just figuring out who was supposed to do what. I'm not going to talk much about that. We're going to talk a little bit about these health unit management committees, which are supposed to be the main link then between the community and the facility. And each dispensary has one of these health unit management committees, which consist of both representatives from the community and health workers, and they should, I should underline should, be in charge then of monitoring day-to-day running of the facility. Okay, so a little overview of the project then. So the main objective was to try to strengthen providers' accountability to citizens and clients. And the intention was to initiate a process then using these local community-based organizations as facilitators, which the communities themselves then could manage and sustain. So one obvious question when we want to start to think about an intervention like this is, why aren't communities already involved in monitoring these public providers? Well, it's going to be a number of reasons you can think of. Here I've highlighted two, and these are actually the two ones that the intervention tried to address. One has to do with access to, or lack of access to, reliable and structured information, and lacking that type of information may make it more difficult to challenge misuse or misbehavior at the clinic. The second constraint has to do with monitoring. So monitoring is to some extent a public good and may be subject to severe free rider problems. So although everyone would like someone else to would like the facility to be monitored, everyone might also want someone else to do the actual effort in monitoring the providers. So these are the two incentives these are the two constraints that the intervention tried to address, and it tried to do that by, first of all, then providing communities with relevant information on the status of service delivery at this particular community and what the community was basically entitled to according to the government set plans. And it also tried to encourage community members to agree on or coordinate on expectations of what is reasonable to demand from these providers, given the budget constraints facing these primary dispensaries, and also to develop a plan that identified which steps should be taken to improve service provision. Yes, so the expected behavioral change ex ante was increased effort then by the health unit staff to serve the community. And here it's important to keep in mind that a worker in a primary dispensary in Uganda, like in many other places, have little pecuniary incentives to exert higher effort. First of all, public money does not follow patients. Hiring, salaries, and promotions are almost exclusively determined by seniority and educational qualifications. And while suspension and dismissals are, in theory, something that the government can use, in practice we don't see it happen very often. The effort choice may, of course, be influenced by social rewards or social sanctions from the community members, and that's, in a sense, something we believe that the intervention may have an effect through. That these types of social rewards or social sanctions were more systematically utilized by community members. Okay, so as I said, there were 50 project facilities, all in rural areas. And the community here, or the catchment area of each dispensary, is defined as the household residing in villages in the 5-kilometer radius around the facility. And altogether, there are approximately 100,000 or 110,000 households residing in these 50 communities. So the facility was first stratified by location and size, and then we randomly assigned half of the units to the treatment group, and then the remaining 25 units to the control group. So let me talk a little bit about the intervention then. First of all, the informational part, and then of the more participation part. So we collected data from two sources, both from healthcare providers and from healthcare users. And the data collection was governed by two objectives. First of all, we needed data to assess how the community views and experiences the quality and efficacy of service delivery. And we also wanted to compare the views of citizens with the views of providers. So in some sense, we collected the same type of data from providers and from households. And then, of course, data were required to evaluate impact. Let me skip a little bit about that. So with respect to the report card, then, a smaller set of the data we collected in the baseline survey was assembled in report cards for the treatment localities. We collected data for both treatment and control in the baseline. But then for the treatment groups, we made these report cards. And the data included in the report cards were identified as the key areas subject to improvement and included data on information on utilization, service quality, and comparison vis-a-vis other health facilities in the district and in the country. So each treatment facility or each community then had its unique report card summarizing the key findings from their area. Before we initiated this project, we did a lot of piloting, and many of them failed quite a bit. And so initially, we thought of doing a much simpler information dissemination procedure by, for instance, going out with posters in the villages. We realized that these posters disappeared basically the second after we had put them up on a post or a tree and used for better things. So we concluded that just putting out the information there would not help. We needed to do somewhat more sophisticated approach. So a so-called participatory approach was used during information disseminations, where the community members themselves were asked to actively interpret and analyze the information. And as I mentioned, we had then staff from these local community-based organizations acting as facilitators here. And the setup through this was being provided was through a set of meetings. There was a community meeting, it was a staff meeting, and an interface meeting. And let me just talk very quickly about these three sets of meetings then. So the intervention started with this community meeting, which was a 2 afternoons event, where the CBOs jointly with local leaders tried to invite participants consisting of a selection of representatives from different strata of society. And while there's some variation in different villages or communities, approximately 150 participants participated in these community meetings. In some places, the numbers were much bigger, actually. And then during these meetings, the facilitators used a variety of methods to disseminate the information in an interactive way. And the objective was to encourage community members to develop a shared view on how to improve service delivery and monitor the providers. So after the end of this 2-day event, the community suggestions for improvements were summarized in an action plan. And obviously, the different communities had different constraints, so these action plans differ across units or communities. But some of the things that were common in this action plan were issues of high rates of absentees, long waiting time, weak attention of health staff, and differential treatment. I think almost all of these treatment facilities had these components included in the action plan. After the 2-day community meetings, there was a health facility staff meeting, so 1-day meeting, held at the health facility with all the health facility staff present. So in this meeting, the facilitators tried to contrast information on service provision as reported by the provider with the findings from the household survey. So my favorite example has to do with waiting time. So the waiting time when you asked households was typically, say, a couple of hours. And when you asked the provider, it was typically a couple of minutes. So during these meetings, then the facilitators presented both of these facts. You report that it takes 2 minutes of waiting time. The average household reports 2 hours, and then they try to, first of all, agree on which was the right number, and then try to analyze why that was the case. Then finally, there was an interface meeting where a handful of participants from the community meetings, and all, or at least part of the health facility staff were present. And here then in this meeting they discussed suggestion for improvements, and in the end agreed on what we can think of a contract, a community contract, or an action plan again, outlining the agreement on what needs to be done, how and when and by whom. So that's basically the intervention. There was after about a 6 months period, the CBOs came back and did a repeat intervention on a much smaller scale, lasting only for 2 days with a community meeting and an interface meeting. In addition, these local community-based organizations were asked to follow up on what has happened during their regular work in these villages. To the extent that actually took place, we don't really know. So just a timeline here. The baseline data was collected in 2004. Intervention started in the beginning of 2005 with this 1 week of meetings. And then we went back around a year afterwards to collect a new round of household and facility data from both the treatment and control group. Let's just skip these. Okay, so outcomes then. So in the end, what we wanted to measure was if the intervention had an effect on the quantity and quality of healthcare delivery, and in the end, improved health outcomes. But we also wanted to try to document changes in all steps in this accountability chains, i.e., did the intervention increase treatment community's ability to monitor the provider? Did it result in any behavioral changes or behavioral changes of the staff? And did it have any impact on other channels or agents in the service delivery change? Let's just skip that as well. So we're going to just simply here look at differences in mean, both in a cross-section setting and over time, controlling for stratification. So pre-intervention, there was no systematic differences in outcomes between the treatment and control areas. So overall, the randomizations appear to have been successful. So what I'll do now is I'll spend the last 5 or so minutes that I have left to talk about these outcomes, and start with question 2, move to question 3, and then to question 1, and probably skip question 4. Okay? So, of course, documenting these processes, if we observe that the community is more engaged and trying to monitor the health facility, is a difficult thing from a measurement point of view. And in particular, since we decided not to have any people on the ground observing any changes. So we have 2 sources of information. We have survey data from the households and the facility, and we have a smaller survey data from these local councils in the villages, and also the CBOs submitted reports of what they observe. So based on these CBO and local council reports, again, this is what I'm speaking about now, is the average picture. There are, again, quite a bit of variation. The monitoring process that followed these meetings was a joint effort mainly managed by the local council, the Health Unit Management Committee, and individual community members. So a typical village in the treatment group had on average 6 local council meetings in 2005, the experiment year. And in this meeting, 9 out of 10 treatment villages discussed issues, including the community contract, concerning the project facility. So clearly in this meeting, the issue of primary healthcare delivery was an important issue to discuss. We find that mismanaged health unit management committees were dissolved and new members were elected in. So the survey data revealed that more than 1/3 of these HUMCs in the treatment communities were dissolved or new members were added to them, while we observed no change in the control area. the CBOs reported that community members did indeed become more active during visits to the clinic and asked questions about this community contract. And they argued that tools such as suggestion boxes, waiting cards, duty rosters, etc., were put in place in several treatment facilities. And this last thing is something we can actually look at using the data we collected. So this is data collected in the exposed survey through visual checks by the enumerators. And here we see that there's a large change in many of these, if we want to call them, monitoring instruments. So while no control area had a suggestion box, 32% of the treatment areas did have one. There's a significant increase in waiting cards, in posters informing about free services, less precisely estimated on posters on patients' rights and obligation. And if you take basically an average of these effects, we see that the effect is large and precisely estimated. We also find data we also look at data from households where they report that the performance of the staff were discussed in village meetings, and we find a 13 percentage points difference, which is a large difference in percentage terms. So taking all these data together and all these information together, we observe that not only did the quantity of discussions about the project facilities increase, but also the subject change from more general to specific discussions about the community contract. So did the community monitoring affect the health workers' behavior and performance, or at least did the intervention affect workers' performance and behavior? Again, this is not necessarily easy to measure, but we look at a couple of different things, a few different things: examination procedures, waiting time, absentees, and the condition of the clinic. And given the time constraint here, let me rush through this a little bit. So on all of these measures, if the patients were, if the medical personnel used any equipment during examination, we find a big effect. Waiting time went down, and here you should keep in mind, as I will show you in a minute, that utilization increased quite a bit. We find a large effect on absence rates. This 13 percentage point number means basically that one more nurse is present at a given day in the clinic. And this management of a clinic is a summary measure of how well kept the clinic is, based on if the floor is clean and walls are clean and so forth. And again, we find a large effect. We looked at the immunization of children. This is based on household survey data, and utilizing the Uganda's National Expanded Program of Immunization. We know when and how many of these doses for different diseases the kids should have, and then we created dummy to account for these requirements. And in the paper you see a lot of these tables. Let me just summarize them. That we find positive effect for basically all cohorts when we look at the average effects at the last 5 columns for the younger cohorts. And we find significant and positive differences between treatment and control households for all 5 vaccines, although not for all cohorts. And the effects tend to be bigger for the younger children. So twice as many newborns in the treatment group had received vitamin A supplements. 42% more newborns have received the first dose of PCG, for example. Okay, so treatment communities began to monitor the health unit more extensively to the extent that we can actually measure this correctly. And we also find evidence that the health unit staff responded or improved the provision of health service. Again, caveat here, the way we measure it. So the question then is, can this increased community monitoring also improve the quantity and quality of health care? So let me start to show you some numbers on utilization here. And these data were assembled then by counting the number of patients from daily patient records held at the clinic. So here we have broken it down to outpatients, delivery, antenatal, and family planning. And the program impact there suggests a rather large percentage increase in all of these four utilization measures. Although for antenatal and family planning, the point estimates are fairly imprecisely estimated. Again, when you take a summary or an average measure of these effects, we find a large effect. We also could look at this from the household perspective, and that's important because it could be the case that what we are observing is people switching from one government clinic to another, although there is actually a fair amount of distance between the different government clinics. But it could be that they are switching from a private provider to the government facility. And that we don't observe in the data. On the contrary, what seems to be happening is that people are switching from traditional healers, and in particular self-treatment, to treatment in the project facility, in the treatment group. Right. Let's look at health outcomes then. So we collected primarily two outcomes, data on child death and weight for age. We weighted all children below 3 years, I think. So these are the data. So we find the first column then shows the under 5 mortality rate in the community. And as I mentioned in the introduction, we find a large effect, about a 30% reduction in under 5 mortality rate, although, as you see, the point estimate is not very precisely estimated. If we instead look at the younger children and infant mortality rates, we do find, again, a very large effect, and also an effect that is fairly precisely estimated. Here is one way to illustrate the results for the weight for age Z-score for the treatment and control group. And as you can see, what has happened is that the mean has shifted a little bit. So kids in the treatment group are not as undernourished as in the control group. But the interesting thing here, I think, is where we see the large shift here is in the children, the undernourished children. And as we know that these are children that are more likely to suffer from infectious diseases, these will be the kids that are more likely in need of health care, and thus those will be the kids that are most likely affected by this type of an intervention. So that's consistent with the results I've shown you before. Let's skip this a little bit. So we do a lot of robustness stuff, and there's nothing in that suggests that there are other channels that are playing out here, that there are behavioral changes higher up in the hierarchy that explains the outcome we are observing. Let me end by a graph where we try to see if it's really one way to try to get a bit closer, a bit inside the box here, to see if it's the community monitoring that actually explains the results. So what we do is we exploit the fact that we have different districts here, and we look at districts where we observe and measure to the extent we can. We measure the changes in monitoring, basically looking at these information and monitoring outcomes. So we make a summary measure of these things, and then we look at the correlation between a district that has observed large changes in monitoring as we measure it, with observed changes in the first case. It's I can't even see. First case is utilization, and the second case is under 5 mortality rates. So here we see, well, at least I could have seen it if I had the paper in front of me, that up in the top graph, you see that in the right top there, most of the treatment communities are situated, while the control group is in the lower left corner. And you see, we observe the opposite in the lower graph, which suggests then that in communities that experience large changes in community monitoring as we measure it, they also experience large changes in large increases in utilizations and large reductions in undefined mortality rate. Okay, let me conclude and give the word to Mary. So what we have done here to study then the effect of this community monitoring, I should say that this is there are some pros with this study. It's a rather large study, but still there's a lot of outstanding questions as well. For instance, we know a little about the long-term effects. This is just one of potentially many interventions to strengthen community participation, and it's probably not the most cost-effective ones. So these are some of the issues we are trying to address now, and as I said, the project is still ongoing. Okay, Mary, I'll leave it for you.
Okay, thank you very much. First of all, I'd like to say thank you to the Poverty Action Lab and especially to the chair, Professor Duflo, and to my colleague Jakob for giving me this opportunity to share this information with you. Now, for the people who may not know where Uganda is, that is Africa, and that is the little country in blue over there. The background, which already Jakob has talked to us about, I don't have to go to details with that, but what you can see is the poor indicators, health indicators over there. Now, also we know we have challenges of the sector. I put a question mark on underfunding. Now, of course, one thing is that I looked at this study as I've participated right from the beginning up to now in the second phase. One, as a World Bank staff who is trying to make a difference to the people of Uganda in the health sector, but also as a Ugandan who is not likely to move away from Uganda but live there, who has relatives and others in the country and therefore would like good services for them. So there is a question mark about underfunding because the sector gets 11-12% of the national budget. That's about below 3% of the GDP. But is it really underfunding or utilization of the available resources more efficiently? So these are the results of the possibly underfunding, in quotes, which is stockouts, personnel, lack of equipment. And one interesting thing that I put there is the abolition of user fees. That was a political announcement in 2001. And then also knowing that this is a country that is decentralized, where you have 34% of the GDP going down from the central government to the local governments. But 80% of this money is conditional grants. In other words, it's predetermined on what it should do, and the local government has no say. Now, going to the demand for health care, you can see the share of the household budget, 7%. It has actually increased by 3 points 3 years before this. And then you can see how people visit the health care. Surprisingly, people prefer to medicate themselves. That is about 15.4. That is those who go to the drug shop and those who do only home care. While only health centers is 26%. And private clinics, not public health centers, because they prefer private health clinics because they think that the staff there are more professional and then they can provide services on credit. And now, as Jakob mentioned, you have the village health, talked about health unit management committees or HUMICs, but we also have village health teams in some localities. And we shall see the role they play later. I have just some of these. Apparently, most of the village health team members are women. They do the training on distributing drugs and doing all other chores related to health. Now, right in there in the experiments, we had issues or the variables that are explored, which Jakob has already mentioned. I don't need to go back to that. And then the question is, if we have to empower service users, what are the requirements? That is something that we are learning and that has come is evident is that access to information, which Jakob too has mentioned. And then, of course, here I pose it as questions because the people we found that, they are even still asking, should we get involved in this? Is this our role? And then, of course, on the other hand, we see how important information is. And then who is available to do the monitoring? That is the need of creating a critical mass to do the monitoring of these service providers. And of course, there is a question of the incentive. What is in it for me, for even service users? And then the political will. The need to have a champion. Now, we are not saying that in Uganda there are no other community-based monitoring efforts. They are there. But some of them might look to you as surveys, but they have elements or components of community-based monitoring. But possibly they've not stayed so long in the communities like we did this time, and even in the second phase. So it was just engaging communities for a short time and then moving on. And we had results, but now what we intend to do is to make it more sustainable. Now, the World Bank's perspective, of course, is in trying to help our client using the results that Jakob has mentioned to you in policy dialogue, and then we are now drafting a new country assistance strategy spanning over 3 years, 09-11. And then, of course, in helping designing operations, not only in the health sector, because these issues actually do pertain to almost all the sectors where you have public service. And then we are trying also to identify key areas of analytical work. One key area is the cost-effective and sustainable community-based monitoring system that can be used. And another one is trying to determine the cost per unit, because as I mentioned to you, that a lot of money comes from the center, or some money comes from the center to the local governments. And the local governments are the service providers. Is this funds enough or not? Where does this money stay? Does it really go to the local government, or does it stay up there at the central government? And the lessons learned, we have also, this is a new concept, which requires popularizing and a champion, as I mentioned before. When initially we went in, we expected people to volunteer among the civil society groups and communities, but we noted down that spirit no longer exists. It's like long gone. And then the other issue is about knowledge about the citizens' rights and responsibilities, knowing that one has a right to a service, and a health service or education is very low. And then capacity building needs for the community-based monitoring, and a continuous and sustained dialogue between communities and service providers is very critical. Jakob mentioned to you the 5 days. We realized that the 5 days is not even adequate if we have to sustain this. So in the second phase, we are having a more sustained dialogue over a longer period of time. And then another issue is some people may not necessarily speak out because of fear of reprisal. Now, let's go to the critical part, the policy implications that I want to talk about here. In discussing with government and looking at the sector policy review and also the health sector review that happens in October every year, these are some of the things that are really being considered. One is to review the decentralization policy so as to have and follow this basic principle of finance follows function principle, especially if we know the per unit cost for providing a service. And then the second one is about the access to information. We actually do have a law in Uganda that provides for accessing information to whoever wants it. But there is still some challenges as to making it operational. The law is on paper, but it has not gone down to the people. And then also the public funding for IEC so that people can be helped change behavior, change attitude towards their rights and responsibilities, and also in popularizing the use and feedback mechanisms. Now here I have 2 question marks, because this is really a challenge. You have 2 different schools. You have a school of politicians who say our voters should not pay anything for any service. On the other hand, you have the technical people and people who are really thinking about the ownership, people owning, services because they are contributing something, also saying something different. And by the way, this is not the only user charge that has been abolished. The others, also including the graduated tax, which used to be, or what used to be called poll tax. So that too was a political announcement, and then all of a sudden there was no graduated tax. All of a sudden there was no user charges, small as they were. So there is a consideration of that, but it has to go through various stages. But it is something that is being thought about. And we also have the thinking. You saw in Jakob's diagram of the citizens, the providers, the users. It is high time that now government is thinking about healthcare delivery as a partnership. Just because it is a public good, it cannot be entirely that the government has just to provide just any service without people having a say or having a comment on what services they are receiving. And therefore, it is necessary to build existing structures like the village health teams and the health unit management committees. One of the things here is we see when all the people work together in terms of partnership, there's quite a change, as you can see from these Ugandans who are trying to catch fish at the same time, together bringing the net towards each other. Now, further on policy implications is the creation of user confidence in the health system. You may have seen from the earlier figures of the demand for health services that people have lost interest in the services provided by government. So there is need to build that again, and therefore it can be done through a number of ways. But one of the things that is being thought about is the identification and institutionalization of regular service user feedback mechanisms. And now also getting the big picture on all aspects of the service. That is, there are other mechanisms, there are other tools that are being used, but the health sector itself has not been very keen in joining other partners and engage and get information, and therefore know what is the general picture about health as a service. And that includes now undertaking and participating in national household surveys, national service delivery surveys. There is one that was just launched last Friday, participatory poverty assessments, etc., so that they can see what people are saying about the services, whether they are satisfied or not, what are the gender responsiveness or implications on the health services, so that then, during the planning processes and sector reviews, they can address those issues, or those issues can be addressed. So I guess that's what I have to say. Thank you.